Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host, Dr. Brian Waterman of Wake Forest in North Carolina. Brian, how are you?
Hey, Peter. Good evening. Hope you're well.
Oh, I'm doing great. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, Wake Forest University, or the institutions of any of our guests. Okay, so today I'm very excited to welcome Dr. Jed Kuhn is our guest. Now, most listeners of the podcast will know Jed, but to briefly introduce him, Jed is the director of sports and shoulder at Vanderbilt in Nashville. After completing his training in the University of Michigan, Jed was a fellow at Stephen Hawkins, and since then, his accomplishments are too numerous to mention. He's now finishing his year as ASES President, and he's done an outstanding job, and we've been extremely fortunate to have him in our leadership role. In addition, he's starting as editor-in-chief for the Journal of Shoulder and Elbow Surgery, taking over for Dr. Bill Mallon. Jed, welcome to the podcast.
Thanks, guys. It's an honor to be here.
So I'd like to just start at the beginning. How did you become interested in orthopedics and in the shoulder?
Well, that's a good story. When I was a medical student at Michigan, I met my wife, Janet, and Janet has her PhD in bioengineering, and she did orthopedic research. And I was not going to do orthopedics. That was her world. She was going to be in academics. I was going to do something surgical, but not orthopedics. I didn't want our worlds to compete. And I had a patient I remember up to this day who was a woman I saw in the rheumatology service. And we were treating her with injections and medications, and she was getting by. And then one day I saw her in the hallway, and she was walking fast and without a limp and smiling. And I said, "Mrs. Smith, what happened?" And she said, "I had my knees replaced." And I just said, "Oh my God, this is amazing. I have to check this out." So I rotated in orthopedics and I loved it. I mean, it was for me. So the rest is history, I guess.
So fast forward then, Jed, you develop an interest in orthopedics. How did you cultivate such a promising niche in shoulder? And then tell us about how you initially got involved with ASES.
Yeah. So, I was a swimmer, and about 80% of swimmers have shoulder pain at some point in their career, as did I. But it wasn't horrible. I didn't need surgery. I did get better with time. But most importantly, I had a mentor, Ralph Blazier at the University of Michigan, who was our shoulder guy at the time. And he really got me interested in the shoulder. At the time, this is, 30 years ago, nobody really knew much about the shoulder. It was a big black box, and everybody was doing a little bit of shoulder surgery, but there were only about a dozen superstars in the world of shoulder that had that as their whole practice. In fact, when I applied for fellowships, my mentor, Ralph Blazier, said, you just can't be a shoulder surgeon. You have to do shoulder and something. It could be shoulder and hand. It could be shoulder and sports. It could be shoulder and trauma, but it has to be shoulder and something. And I like sports, so I went to a sports fellowship that had a strong interest in shoulder. But I started to learn about the shoulder. I learned about Codman's paradox. And if nobody knows what Codman's paradox is, you need to open up Codman's book and read about it. Because it is clearly one of the mysteries of the shoulder that intrigued me and got me interested in the joint. And I've been fortunate to be a part of the evolution of the shoulder. Back when I was a fellow, we were just barely getting started with shoulder arthroscopy. Everything was done open, and things have changed so much in the last 30 years. It's been a great ride.
Now, part of the thing that's interesting to me about that story is how much has changed in your career. I think many of our trainees think, okay, I'm going to learn how to do this operation and then I'm set. Clearly during your career, you've had to learn new operations, new approaches. Tell us your approach for that. So when something new comes out, how do you determine this is something I'm going to do or not do? And then how do you learn something new once you're already attending?
Yeah, so you always have to keep learning. Every year when we have our fellows come in the first week, we watch a movie called Hero Dreams of Sushi. And it's a documentary about the best sushi chef in the world. And when the documentary was filmed, he was 80 years old, and he runs this very small restaurant. But he's always thinking about how to make his sushi better. He's always trying to perfect the experience that his clients have and perfect sushi. And if you train with this guy, you spend about 5 years learning how to make rice before you can touch fish. And it's an amazing detailed documentary about the way people think in Japan about perfecting their craft. And there's Japanese words to describe it, which I won't go into here, but it's kind of over there. It doesn't really matter what you do. If you're a cab driver, that's fine, as long as you're the best cab driver in the world. And so you're always trying to perfect your craft. And I like my fellows to watch this film because this guy does this for sushi, and they're going to be surgeons. And so you're always thinking about how can I get better at what I'm doing. Uh, Things change, and honestly, if I look back on my fellowship, there's very few things surgically that we do the same in the world of shoulder. And for me, the best experience I had in fellowship was learning how to manage patients, and both Stedman and Hawkins were phenomenal at that. And those are the things I still carry with me today. I still say things Hawkins said in clinic and still approach patients the same way, trying to understand who's going to do well with the operation and who's not, trying to understand their expectations. For me, those are the things that are really important because the technology changes. And getting back on your other question, I don't adopt new technology quickly, and maybe I'm too conservative that way, but I waited about 10 years before I jumped on the reverse arthroplasty bandwagon because I wanted to be sure it had legs, it had durability. It's such a radical design change. I wasn't sure it was going to do really well. And so I tend not to jump on things quickly. I tend to watch and look for the literature and then make sure it's going to work before I'll apply it to patients.
I love the parallel in sushi chefs and shoulder surgeons. It's a little disconcerting that they spend 5 years perfecting the art of cooking rice, and that's the amount of time we spend in orthopedic residency, but I guess I digress.
It's a great film. It's worth a watch. And if you watch it as a surgeon, you'll get it. You'll understand what he's about.
Yeah. And you've had incredible mentors, without question. One of your biggest contributions to really the shoulder community at large is really the development of the Moon Group. I'm really interested in the origin story. How did it start, and what have been some of the major milestones or aspects of it that you've been most proud of?
Well, that's a great question. This has probably been one of the most fun things I've done in my whole career. Kurt Spindler was my partner at Vanderbilt, and I've always been interested in clinical medicine, but I started my career at the University of Michigan, and they really didn't have the systems in place to do good clinical research. They were really biomechanics. And so I was doing biomechanics research, but really my love was in clinical work. And then when I came down here to Vanderbilt, Kurt Spindler had started the Moon ACL group and had really worked out a lot of the details and solved a lot of the challenges and problems. So I was just kind of riding in his wake. He already kind of established a way to do this. And I did the same thing for shoulder. And I used a lot of his partners who do shoulder surgery. So all the knee people that he was working with the Moon ACL group, I tapped their shoulder people in those institutions, and we created our Moon Shoulder Group. And we started with about 14 of us and people from all over the country, different sites, both academic and private practice. And they were all pretty young and all excited to do this. And back then, not many people were doing multi-center research, and we understood the power of that. And so we took about 2 years getting started. We did a lot of inter-observer agreement studies. We did a lot of systematic reviews, trying to get our practices lined up. We wanted to use the best evidence we had and try to eliminate as much variation in our practices as we could. And when we couldn't come to an agreement or couldn't find literature, we would kind of sit around the table and try to come to some agreement. We didn't use the Delphi technique back then. We just kind of came to agreement. And what's interesting is one of the things we couldn't agree on was who needs surgery and who doesn't. There was a lot of variation across the country about surgical rates, and people from different parts of the country approached patients very differently, and we realized that. So that's what kind of launched our first study.
Yeah, I think that's very interesting to hear that is kind of the impetus, because certainly as you move forward in Moon, one of the main contributions has been that you've made has been on the non-operative treatment of rotator cuff tears. I think this is really going to be one of your lasting legacies. It's produced some data that's certainly changed my mind. It's changed my management. It's data that I give to patients every day in clinic in terms of not only this is the success rate, but this is the durability. So tell us a little bit. I mean, you mentioned, that your approach has changed from open to arthroscopic. You mentioned that there are still phrases you use from Hawk. How have your thoughts about rotator cuff tears evolved as you've done these studies and as things have changed?
They've completely changed. There's something called confirmation bias, and that's when you have a set of beliefs, and when data is put in front of you, you tend to accept the data that falls into your beliefs and reject the data that does not, and that's called confirmation bias. It's really strong in politics, but it also happens in science. And I was taught that rotator cuff tears needed surgery. I was taught that the patient who comes to your office and has shoulder pain and has an MRI with a rotator cuff tear, that cuff tear is causing their pain and they need to have it fixed. And so almost everybody I saw, I would get surgery unless there was a reason I couldn't operate on them. And so we knew not everybody needed surgery. We thought as a group that maybe the little old lady who lives in the nursing home who plays bingo, she might not need surgery, but everybody else does. But we didn't know. So we did this study, and it was supposed to be a pilot study. We were just going to send everybody through therapy, and we thought about 15% of the people would get better with therapy, but everybody else would need surgery. And we thought that the people who would get better with therapy were going to be people with low demand, people with smaller tears, people that were older. And so we did this study. We sent about 450 patients through the best therapy program we could find. And much to our surprise, about 80% of the people got better with the therapy. And I didn't even know how to wrap my head around that. I remember the day we looked at that data and I said, oh my God, this is incredible. What's going on here? And then I usually think clearest in the morning. And I got up one morning and I was taking a shower and I was putting numbers through my head. And I was realizing that, okay, let's say, 20% of people have rotator cuff tears in the United States. And I was doing the math in my head about how many people that would be. And it occurred to me that we're really only operating on about 2% of all the people with rotator cuff tears in the United States. And that's when I realized that, then I understood why the physical therapy was successful. And it has changed completely the way I think about rotator cuff tears now.
Peter and I just returned back from Munich, and it was an incredibly stirring conversation that we're having about the natural history of rotator cuff disease. And as we survey the landscape of what's available in the literature, that from Jay Keener and Stefan Moosmeyer, who's there, and Nobu Yamamoto, all their data suggests that rotator cuff tears, they tend to get larger over time, particularly as they get symptomatic. And so as I juxtapose your work next to theirs at even greater than 10 years follow-up, how do we reconcile these disparate bodies of evidence? You're a very thoughtful guy. I'm curious in the way you manage that in your mind.
Yeah, that's a great question, because you're right. We know that there are 22.6 million Americans that have rotator cuff tears. We know that we operate on about 500,000 per year, which is 2% of all the people with rotator cuff tears. We know that when we do physical therapy, 70 to 75% of the people get better, and the results last for 10 years. They don't seem to be falling off the edge of the earth and having surgery down the road. We know that the number one predictor for having surgery was whether or not the patient thought therapy would work, although activity level and workers' compensation had a role as well. But the majority of people can be managed successfully with physical therapy. But on the other hand, we see patients in clinic that have massive tears that we don't have good solutions for. That's like dozens of things we could try, that are younger patients that have problems. And so what I've come to realize recently is I think that if you look at all the people in the world with rotator cuff tears, most of them are asymptomatic and not coming into your office. There's a population of people that have pain in their shoulder but come to your office, and they're going to do fine with physical therapy, and their results will last at least 10 years. But there's a small subset of people that are probably genetically predisposed to having rotator cuff disease, and their rotator cuffs wear out rapidly. And we know that progression, if it's rapid, can cause more symptoms. But in our study, 10 years, half of our population should have had progression, and likely did, but their patient-reported outcomes didn't change much. So what we're talking about here is a very small subset of people that have real problematic rotator cuff tears. For most people, I would call the rotator cuff tear to be incidental. It's not causing their pain. It gets better with therapy. It's not something they need to worry about long term. But there's a small subset of people that likely have, as I mentioned, a family history, a genetic predisposition, and I call it progeria of the rotator cuff. Progeria is a genetic disease where children age rapidly, and a 10-year-old might look like he's 80. And I think there's a small subset of people with rotator cuff tears that have that process where their rotator cuff ages rapidly. And if they have more rapid progression, they're going to have more symptoms, and they're going to be in your clinic more. Those are people that show up in their 50s with very large tears. They have horrible fatty infiltration. And, we have dozens of operations to try to approach those people, which means not one of them is the best. I don't know if I honestly don't know if we have a good surgical approach to treat that genetic problem. But I think those are the people that influence us and make us think that everybody needs surgery. But the reality is, it's a small subset of all the people with rotator cuff tears.
Certainly, we've worked on the genetics of rotator cuff tears at the University of Utah, and I could not agree with you more that there is a genetic contribution, and that I do think there are those patients, as you mentioned, where it's a more malignant disease. It's almost like there's two types of rotator. There's malignant and benign, just like there can be for cancers. But one of the things I want to ask you about was Stefan Musmar's RCT. He said some things in our interview that really stuck with me. One of the things he said his data lines up just with yours, which is that the non-operatively treated patients in his cohort actually did better, that they are still significantly better than when he first met them. And that he said, when we asked him, well, doesn't your study show that everyone should get operative treatment? And he said, no, my study shows that the patients who were treated non-operatively also did well, and not all patients need surgery. But he also said the patients in his study that receive surgery do better than the patients that are treated non-operatively. He just said maybe not all patients need that top result. Do you think that that's true? That it could also be that maybe the way to reconcile these two studies is that his studies shows the same thing as yours, that non-operative patients do better than if they received, that when they first had the tear, but that it could also be true of your findings that had you taken all of those patients in your study, treated them surgically, they could have been doing even better. Or do you think that that's a false interpretation?
Well, great questions. The first thing I would say is this. It depends how you define better or define your outcomes. So if you look at failure of treatment, if you treat patients non-operatively, about 25% will fail and have surgery. If you treat patients surgically, about 25% of your repairs will fail. So it's a toss-up, really. If you use the constant score to measure your outcomes, you're going to get better results with surgery because about 25% of the constant score is based on measuring strength. And we know that if the repair heals, those patients will have better strength than if it didn't heal. Their patient-reported outcomes may be the same, but the strength will be better if the repair heals. And so the constant score, if strength is important, that's an important outcome measure to use, but it does bias the results towards surgery a little bit. And the other thing that happens is, if you look at Musmayer's data, about a third of the patients who had surgery, and that's true with Keener's study and that's true with our study, they have something going on with their biceps, and they have surgery performed on their biceps tendon. And that will also influence the results toward better outcomes with surgery, because obviously you can't fix somebody's biceps with physical therapy. So I think all of those things together tell us that the results are fairly comparable. If your patient has concerns about function or weakness, I think surgery is a much better option for that patient. But if their concerns are pain, it's likely their pain will be treated very effectively with physical therapy. The other thing that I worry about is, I think we need to think about this differently. We can't look at everybody who with a rotator cuff tear and put everybody in a population. What we need to do is identify those people who are going to do well with therapy and identify those people with the progeria or the genetic predispositions, or who are going to have a hard time, because those are the ones we need to focus on. When you put everybody in a pool and let's say 2% of the people have this genetic problem, the pool washes it out, and it dilutes out that effect of those really bad patients. And so I think we have to be a little more careful about our patient selection. And at some point, I think we'll have a blood test that will say, you have an incidental cuff tear, you have a consequential cuff tear. And the blood test and the genetics will help us figure that out.
First off, for those listeners that had progeria on their ASES bingo card, congratulations. Way to integrate that into the podcast.
It's a great word, and it describes it well. I mean, cuff disease is a process of aging. It's not a tear. It's not traumatic for most people. It's aging. And if you have a rapid accelerated aging, that's progeria of your rotator cuff.
No, your thoughts resonate with me, and I agree with you wholeheartedly. I think, we're so married to this narrative of the rotator cuff fix. Our patients come in with all these preconceived notions, and very often the discussion encouraging them towards a non-operative treatment trial is almost as painful as doing surgery. So I'm curious, in your current clinical practice, Does everyone get a trial of conservative treatment? How does that work? The nuts and bolts as you see them in clinic.
Yeah, so I really probe into how their shoulder is bothering them. And for most people, it's pain. If they don't come in and say, I'm functionally weak, I can't do the things I want to do. I would say most patients come in and say, I can't sleep at night, it hurts. And so for those people, yes, they all do physical therapy. Even I can even get people with massive tears to have better function and do pretty well and end up pretty happy with their results. But if somebody has functional problems, weakness, they can't do the activities they want to do, for me, that's an indication for surgery. And so I divide it along those lines. And I can tell you that most people, their issue is pain, not weakness. And so most people in my practice end up being treated effectively with therapy.
Can I follow up with you with one thing you said that I think is super interesting about the biceps? So you had mentioned that there's a performance bias, a treatment bias, because many of the patients who undergo rotator cuff repair also undergo treatment of their biceps, and I could not agree more. So let me ask you, I know you're working on a similar RCT to Stefan Musmeyer's study, I think a larger study. When you think about that study, how are you going to address the biceps? How do you mitigate that from a scientific perspective?
Yeah, it's too late for us to do that because these thoughts are relatively new for me. But we've already enrolled close to 200 patients in our randomized trial, so it is a large trial. And we've stopped enrollment. Now we're waiting for the 2-year follow-up to be able to say what we can say with it. And it's a big national trial here in the United States called the ARC trial. We did not exclude patients with biceps pathology, which might have made it cleaner, but it would have limited our ability to enroll people. It was very hard to do this trial. We got hit with COVID, and it shut everything down, and it was very hard to get the 200 patients we needed to do the data. It took us years to do that. So randomized trials are not easy, and I tip my hat to Musmeyer and everybody else who's done them. There's only about 4 or 5 in the literature because they're very, very hard to do. We hope our study is powered enough to ferret that out a little bit and see if having a biceps pathology made things better for patients who have surgery. But it's going to be hard to figure that out. And again, if I were going to try to redo a trial, I probably would have excluded people with biceps pathology just to know the effect of the cuff tear alone. But I don't think we'll ever get to that point.
Yeah, that's fantastic. Certainly, you've led the field in this discussion, and I would really consider you a Renaissance man because, in addition to all your wonderful work on the rotator cuff, you've also been really a longstanding contributor to our understanding of the throwing shoulder. And as you talk about mechanistic development of slap tears to the role of the coracohumeral ligament, I've always learned a lot from the things that you've put into the published literature. I was hoping we could go off script a little bit, and maybe you could just lend us your top pearls for approaching the elite overhead athlete with shoulder pain, because I've got my pad and paper ready. I'm ready to take these down.
Well, honestly, it's not me. I mean, I learned so much from Ben Kibler, frankly. It's incredible. And I have to tell you a couple stories. The first is I remember distinctly I had a eureka moment. And I don't know if you've ever had a eureka moment in your life, but I had one with regard to the throwing shoulder. I couldn't understand the throwing shoulder. I didn't get it. And I would look at these pictures in Sports Illustrated of people with their arms rotated back so their forearm is parallel to the ground in the late cocking phase of throwing. And I'm saying, how do they get there? What's going on with this? And my brain is just swimming, and I'm a fellow, and I'm sitting in an airport, and then all of a sudden, it's like the sky opened and the birds were singing, and I had a sudden glimpse of clarity. And that clarity is the human shoulder has evolved to throw. And what's interesting is, and it sounds crazy, but it's if you ask any question about the human shoulder and the anatomy and what does what and why is it the way it is, and you put it in the context of a joint that he has evolved to throw, all of a sudden, all these questions about the shoulder make sense. So if you look at primates, the greater tuberosity is higher in primates than it is in humans. In humans, it's depressed. And that leads to the watershed area and leads to potential rotator cuff tearing, which may or may not be a good thing to do. It's like, why? Why is our greater tuberosity depressed? If you ask, what does the coracoacromial ligament do? It connects 2 pieces of the same bone. That's weird. Most ligaments don't do that. They connect one bone to another bone. If you ask, why is the subscapularis so tendinous? The supraspinatus and infraspinatus and even teres minor are not tendinous at all. The subscap is 2/3 tendon. Why? What does the biceps do? The people used to think it was vestigial. If you think about it in the context of throwing, all those questions get answered because they all help the shoulder throw. And I'm not going to go into a lot of detail about that. I actually wrote a paper in a throwaway journal about that. But it all of a sudden all made sense to me. And to this day, I will argue with anybody that the human shoulder evolved to throw, and the geometry, the anatomy, the questions that we have about the human shoulder are all answered in the context of throwing, which obviously throwing was very important in human evolution. It helps us get prey. It helps keep predators away from us. And we do it better than any other primate, any other species on the planet. We can affect change at a distance. Most animals can't do that. So for human existence, throwing is very important, and our shoulder has evolved to throw. So that is the foundation of everything. So when you look at throwers who have shoulder pain, of course, baseball pitching is very different than hunting or keeping predators away, but it's somewhat similar. When you think about baseball pitchers who are breaking down, you have to think about, well, what's going on here and why are they breaking down? And most of them are overuse injuries. They're not acute traumatic events. And so most of them can be managed effectively without surgery. And we do things like core strength, which is very important in throwing. We work on the scapula stabilizers. We stretch the posterior capsule for GERD and stretch the pec minor and get the scapula function better and look at the mechanics and improve those. And once we do that, most pitchers are able to get back, even though their anatomy may be distorted on the MRI. And then you can think about, well, let's think about this anatomy. I mean, if we take MRI scans of asymptomatic throwers in spring training, they can have labrum tears, they can have articular side partial thickness cuff tears, they can have all this pathology. But then you step back and think about it, well, what are these structures doing when someone's throwing? And the reality is that pathology is what lets them throw. If you have an articular side tear on the rotator cuff, well, as it turns out, the coracohumeral ligament has fibers that invest into the capsule, and that's a restraint to external rotation. And pitchers are trying to get as much external rotation as they can because that correlates with the velocity of the ball. So failing in the capsule gives them more external rotation, which lets them pitch better. And if you try to restore anatomy to normal in a throwing shoulder, they'll never throw well. They'll never get back because that pathology is adaptive. And so I actually published a paper recently on it called Adaptive Pathology of the Shoulder, and it argues that a lot of the things that we see on the MRI that we would consider to be pathologic are actually adaptations that allow the pitcher to pitch well. And when we try to get them better with therapy, and we're successful for most, that's great. They still have the pathology, but now they're back up on the mound and they're pitching well. But there are some people that don't do well with physical therapy and they need to have surgery. And as a general idea, our goal is not to make their anatomy normal, but to bring them back to the edge of the cliff so they can have that pathology and still throw, but not correct it back to normal, because they'll never be a good thrower if we do that. And I think those are lessons we've learned over the last 30 years in approaching pitchers for sure.
Yeah, I could not agree with everything you just said about the adaptive pathology more. And that's, I think, one of the things that we need to really work on teaching our trainees so that they don't go out into the field and think that every thrower that comes in has a partial thickness articular sided cuff tear and a slap tear that needs to be fixed, or those players will not get back.
Yeah, we've learned that lesson. We used to fix those things and they don't get better. And so now, again, we're trying to get people on the edge of the cliff. We don't want to bring them back to normal. We want to make them have a shoulder that has that pathology that lets them throw, but not over the edge where they're having pain and difficulty with throwing. It's a very delicate thing. And, that's why experience helps. I mean, you talk to people like Neil Elatrash and Jimmy Andrews, and they figured this out a long time ago, that they can't make these people normal or they'll never pitch again.
Now you're ending your year as president, and obviously it's a huge amount of work and incredible service to our society. Tell us a little bit, what do you feel were kind of the greatest challenges or accomplishments of your year, or the things you really wanted to set out to achieve that you did achieve, or the things you think maybe people will look back and say that was Jed's legacy?
Well, I didn't do this to leave a legacy. Well, the thing I want to mention, though, is the culture of this society. We are busy academically and other things. We could spend time working with the Academy, with Arthroscopy Association, with the AOSSM. I'm sports trained. I'm shoulder trained. there's a million different places I could spend my time. But what drove me to the Shoulder and Elbow Society is its culture is based on service, which I love. You know, it's like we have 1,400 members, and every year we get more than 700 people requesting to be part of committees and part of things that we do. That's more than half of our group. And we don't have enough committee spots to put everybody on something. And it's amazing that the people in our society are so committed to serving. The near circle, which is the highest echelon of membership really that our society offers, is not based on who you know. It's not an old boys club. It's based on well-defined criteria for serving the society, which I think is awesome. It's a meritocracy. If you are chairman of this committee, which requires a lot of work, you'll automatically get into the near circle. You don't have to like go to cocktail parties and shake hands and smooge, and it's not a who you know. It's what you've done. And our mission statement, the first words are to serve. And so that's what I love about our society. It's committed to serving. And so to serve as the president is like the greatest thing I could do. It's just an honor to be able to do it. And some presidents come in with agendas. I was given an agenda to help build the multi-center research groups, and you'll hear about that at the meeting. We've been very successful. I've helped to assemble some of these groups that are just really going full bore and getting really good data and starting to collect multi-center research data on a lot of different topics in shoulder and elbow. That task was given to me by Tony Romeo and Buddy Savoy to kind of help assemble these groups, and they're really going great. So I'm really excited about that. Our foundation is generating revenue to help support these groups and help support the mission. That's been really good. Joe Aboots and John Ticker and Tony Miniacci have all chaired that that foundation and have done amazing things to generate revenue. And this year we've raised over $400,000, almost $500,000 in just the past year. So I'm really excited about doing that. We had our 5-year vision retreat and set a course for the next 5 years of things we need to work on. And if you said what's Kuhn's legacy, that's probably that. I helped to coordinate people and get a team of people together. We had a retreat. We had a committee. We've identified about 70 different action items that are going to propel us into the next 5 years of things to work on and make our society better. But there's a million things going on. This is not the Jed Kuhn show. I mean, the reality is I take over the helm for a year, and then Joaquin will take over next year, and then Tony Miniacci will take over next year, and somebody else is going to take over the next year. But it's all the volunteers, it's all the people that chair the committees, it's Anna and the whole crew in the office. They're the ones who make the boat go. I mean, we just take the steering wheel for a while, but this is an amazing enterprise, and it's great to be part of it.
Yeah, you can hear your passion when you talk about it, and I would agree with you that it's a unique culture of very high achieving individuals, and certainly you're the embodiment of that. I'm curious about what would be your favorite memory of this year as president of ASES. Do you have one in mind?
I don't know if I have a favorite, but I can tell you that one of the things I really enjoyed was going down to the mentor-mentee meeting that was held in Florida and getting a chance to meet a lot of our younger people in the society who are passionate about it just as I am. And they want to get engaged, they want to be involved, and they want to do all these things. And just to watch that, it just makes me feel good that we have people like that in our group that will keep this thing going for the next 3 decades at least.
So you're starting on, embarking on a new role as JSES editor-in-chief. Bill Mallon's been in that role for a long time. It's a hugely important role for our field. A mountain of work, challenging politically to tell different authors that their papers are not going to be published or that they are going to be published. Obviously, Bill Mallon has navigated us from one journal to now multiple family of journals. Tell us what are your thoughts as you approach that role, and what do you think the future really holds for the Journal of Shoulder and Elbow Surgery?
Well, I think the future is bright. Again, when I started this career 30 years ago, there were probably 9 people that were specific shoulder surgeons, and they trained people, and then they trained people, and then they trained people, and now we've got 1,400 members in our society who are shoulder experts. And there's people that aren't part of our society that should be part of our society that are doing shoulder practices as well and doing research and getting data for us. So, it's the growth has been incredible, and the challenges with that growth we're faced by Bill Mallon and will be faced by me. We get 1,700 papers a year, and we can only publish so many. And it's not we're not trying to offend anybody. We're trying to make their data better and trying to make their science better. And when somebody submits a paper, it should never be condescending or obnoxious or your data sucks. It should be, oh, this is interesting data. How can we make this better? How can we present this better so it's more validity? And that's what the reviewer's task has to be, to help us do that. And we're going to be training people how to review papers. This is an advertisement. We're having an instructional course lecture at our open meeting at the annual meeting in next month. And so if you're not sure about how to review a paper, it's free. Come and learn, and we want to make you good at reviewing. But I think the journal's in great shape. Bill Mallon's done an amazing job taking the challenges he faced and creating 4 different journals that are all great journals and have great data in them. The Seminars in Arthroplasty is the official journal of the Shoulder and Elbow Registry that the Academy has produced. The International Journal is fantastic. It's our open access journal. The Techniques and Reports Journal is doing well. It's amazing how many submissions they get. I think that could grow and be more video oriented. The challenges I think we're going to be facing are, how do we get information out? The print journal is basically nobody really reads anymore. People my age might, but younger people need to get their information differently. And so we have to figure out different platforms to share information, whether that's podcasts or infographics or using social media. We have to figure those things out. So I think that's going to be my challenge, is to try to, how do we get the information out to people that are interested in seeing it and really promoting that. We're always going to be trying to make the science better, and it has been. I mean, the level of evidence for papers in the journal have just gotten better and better and better. So when you read those articles, you can be sure that they're valid and they can help your practice, and not based on relatively low level evidence. So it's a good time to be involved in research and science. I mean, we're doing really great things in the world of shoulder and elbow surgery.
Yeah, I think editors-in-chief are the epitome of servant leaders, right? They do the thankless work and a lot of this in the background. So if anybody knows you, do not bet against Dr. Kuhn as he leads this into the next level. Really many of our listeners are surgeons, but there are also several that are early in their careers. They're junior learners, they're orthopedic trainees, junior surgeons. Maybe can you offer some advice to these surgeons as they seek for ways to best succeed in their early careers?
That is a big question. I think, well, this sounds weird, and I apologize in advance, but it helps to know who you are as a young person. And I mentor a woman who is a trauma surgeon in our department. Rick Wright, our chair, has us partner with younger people of different disciplines to mentor them. And he assigned me a woman who is a trauma surgeon, who's a fairly young trauma surgeon. And this sounds weird, but I said, I want you to write your obituary. I said, 30 or 40 years from now, you will leave the planet, and there will be somebody who writes something about you that will be your legacy. And what is it going to say? So I want you to go home and think about it and write your obituary. And she looked at me funny, and she said, okay. So she did. She thought about it, and she wrote it, and she brought it back, and we met again, and we kind of went through it. And she had things in there like, I want to be known as a respected, excellent surgeon. I want to be known as an educator. But she had things that weren't in there that were just as important. There was nothing about her leading, nothing about her being president of the society or doing this or doing, academy president. There was nothing in there about, changing the world with new operations and innovation. And so when you know who you are and kind of define those things, you know where to put your energy, because you're going to be asked to do a lot of different things in a lot of different spaces. And the key thing is knowing where to put your energy and knowing what you want to leave behind as your legacy. So for her, she wants to be great at education. So we're going to focus on that. How do we make you a great educator? How can you educate the world about pelvic and acetabular fractures? How do you become a better surgeon? How do you develop those skills? And so we kind of set a course for her at this point based on that document that will put her energies where her interests are. And granted, those may change as you go through your career, but I think it helps to sit down and reflect and figure out who you are to help you determine where to put your energy. And there's different tools to do that. Writing an obituary is one tool. but there's other ways to try to figure that out. And that's where a good mentor comes in. He won't tell you what to do. He will ask you, what are your interests? What are your goals? What are you trying to do? And then help guide you into those areas. So I think if I were telling a young person what to do, I would say, number one, find a great mentor who will help you understand who you are. And number two, spend some time trying to think about who you are, so you can figure out where to put your energy.
I think it's such great advice to begin with the end in mind. We have one question we've asked many of our guests, and I wanted to ask you as well. It's kind of an off-ball question, so think about it for a second if you want. Here's the question. If you could have dinner with any person in history, any person, dead or alive, who would you have dinner with, but also where would you have dinner?
Well, that's a great question. In the world of, can I give you three answers?
Only if you order them from 1 to 3. You're supposed to pick one person. You're already violating the rules here.
All right. Codman is a personal hero of mine, and it's because I'm a shoulder surgeon and I read his book. But Codman was a very interesting guy. Codman was Harvey Cushing's roommate in medical school. And everybody knows who Harvey Cushing is, but nobody knew who Codman was. And Cushing said Codman was the smartest man he's ever met. Codman wanted to collect patient outcomes before anybody wanted to. In fact, he put up a cartoon in front of the Boston Medical Society telling his colleagues, you guys are all full of crap. You got to collect data on your patients. This is ridiculous. You need to be doing this. And he was fired from his hospital at Mass General for showing this cartoon that made fun of the administrators and the surgeons who kept their hands over their eyes so they couldn't see what was going on. And he wrote in his biography, he goes, 100 years from now, they will show that I'm right. And sure enough, 100 years later, we're collecting patient-reported outcomes. Codman knew everything about the shoulder. If you read his book, if you think you've discovered something new, like a rotator interval lesion or something like that, Codman wrote about it. Codman knew it without MRI, with good physical exam skills. And he was so committed to what he wanted to do that he died a pauper. He had no money at the end of his life and was buried in an unmarked grave. Fortunately, that was reconciled a few years ago where they marked his grave because they recognized his contributions. And it wasn't just in orthopedics. He did work in ulcer research. He did work in tumor research. He set up the first sarcoma registry. I mean, he was a really fascinating guy who left a huge imprint, but didn't do it to be a celebrity. He really did it for all the right reasons. So I'd say Codman would be my number one guy. And where would I have dinner? Oh, I don't know. Somewhere in Boston where he lived, so he could tell me about what it was like to work in his era.
Well, I love that answer. That's an all-time great. Thank you so much for coming on the podcast. We know that you have a lot going on, and it's extremely meaningful to us to be able to have this conversation. And our listeners, I'm sure, will enjoy the back and forth about rotator cuff tears, but also all the other things you've accomplished as ASES president throughout your career. So thank you for your time.
Well, listen, I just want to thank you, Peter, and you, Brian. This podcast is amazing. I listen to it every time it comes out. It's so entertaining, and you guys do a wonderful job, and thank you.
No, thanks, Jed. Thanks for your thoughtfulness and your levity and really just distilling things into all that really matters, and your commitment to the organization is reflected in your body of work. So congratulations on your year. It's been great to watch it unfold.
Thanks. I'll be happy in about a month when I pass that gavel off to Joaquin.
Well, we look forward to seeing you on the masthead at JSES. And so I think that's about all the time we have for all our shoulder and elbow listeners out there. Don't forget to subscribe, and otherwise we'll see you next time. Thank you.